Right, thank you everyone for joining. I think we're just gonna wait just a minute longer, um, and we'll start in just a minute. Thank you. Okay, thank you again, everyone, for joining our webinar this evening. I'm honored that you all are sharing your Thursday evening with Tiana and I tonight. And I'm really excited to talk to you a little bit about our respiratory program, and in particular, the changes to asthma management, and especially mild asthma that have been upcoming very recently. We're also going to be talking about more pharmacy specific details as well, and kind of helping out and pointing out to various tools and resources to help you integrate these changes into your pharmacy as well. So let's move on to the next slide. And if you have any questions during this webinar, please feel free to put them in the chat box, and Tiana or I should be able to address your questions. Okay, so just as an introduction, I'm sure many of you know who's with me, Tiana, but just an introduction for myself. My name is Molly. I'm a pharmacy intern. So I graduated recently from the Leslie Dan Faculty of Pharmacy at U of T. So I currently have my PharmD. And I'm sure, as many of you know, my class is the one that has unfortunately been affected by COVID, and we've had our licensing pushed back a bit. So right now I'm a pharmacy intern, and I just want to thank Whole Health for the opportunity to work on this project. And I just want to put a little plug in there for my classmates as well. So if anyone is watching this and is looking to hire, please consider hiring a pharmacy intern. We really appreciate your support and all the advocacy we've received so far, but we do need to continue to receive your support upcoming as well. And I'll get off my soapbox and pass it on to Tiana.
Well, what I was going to say is I can personally attest to how great pharmacy interns are. And I think that everyone at the end of this presentation will see as well, because I think Molly's done a really great job, and we'll walk you through some really excellent slides that really break down the recommendations in a very practical way for you to integrate into your practice. So highly recommend the intern, as well as highly recommending updating your practice according to the new guidelines, which we will talk about today. For anyone who doesn't know me from outside of the banner, perhaps, my name is Tiana, and I'm the Director of Pharmacy Innovation and Professional Affairs at Whole Health Pharmacy Partners.
Thank you, Tiana, you're too kind. Okay, and we just want to point out here that AstraZeneca Canada has supported the development of both this webinar as well as our respiratory program. We really just want to thank Rita as well for giving us the opportunity to work on this and to provide it for you guys as well. Okay, so this is the agenda of what we're going to be going over tonight. So initially, just a quick overview on asthma, followed by the changing practices that we have seen recently, and then more details on how to actually integrate this and apply this in your pharmacy. So starting off with the asthma overview. So why is it important to talk about asthma? And why is it important for pharmacists to understand asthma and talk to patients about asthma as well? So number one is its prevalence. So it's the third most common chronic disease in Canada, with over 300 Canadians diagnosed daily. In addition to the burden on the patient, it's actually a huge burden on our society as well, with over $2 billion annually in direct, which are costs to healthcare and costs of medications, and indirect costs, so cost to productivity, missing work, and school. And that number is expected to go up by 2030 to double, actually. So in addition to the huge burden that asthma is, the more relevant part for pharmacists is that we can actually make a huge impact because of the fact that the majority of patients are not well controlled. So this data on this slide here takes from a survey, the Asthma Control in Canada survey from 2016, where patients with asthma in Canada were asked about their asthma control. And over 90%, as you can see on this slide, 93% perceived their asthma as very or somewhat well controlled, whereas those same patients, actually 90% of them, identified with at least one criteria indicative of poor control. So the bottom line is that asthma patients in Canada living with asthma don't understand what it means to be having their asthma under control. And how this ties back to pharmacy is that pharmacists are in the ideal position to screen patients who are having poor asthma control and also educate them about the possibilities of what they can really achieve with their asthma control as well.
Yeah, and I think what Molly's pointed out in terms of the survey results is that patients need to be prompted for more specific reflection of their asthma control rather than asking questions like, how is your asthma controlled? Because people will automatically respond things like good. But if you actually ask them, how many times per day or week are you using your SABA rescue inhaler? Or how many times per day or week do you have symptoms that interfere with things like going to work or school? Or how many times in the last week has asthma impaired your ability to do something or an activity that you wanted to do? And so that can be more fruitful reflection on the patient's part and really identifying the limitations that asthma is involved in their life. And we'll get into a few slides later how we can ask these questions and what tools exist for assessing asthma, but there really is a big part of the pharmacist's role to ask these specific questions and to hopefully set goals later that are specific to the patient as well.
Exactly. And I'd also just like to point out on this slide that, as we saw in the previous slide, there is a big discrepancy between what patients perceive to be good control. And sometimes there's a discrepancy between healthcare providers as well. So just as a question, if a patient were to come into your pharmacy, at what level of SABA use? So for example, how many times per day or per week of them using SABA would make you stop and pause and think, you know, this person really needs an intervention because their asthma is not well controlled. Just think about that for a second, and then we're going to go into it in the next slide. Okay, so this slide outlines the GINA criteria for asthma control, and GINA stands for the Global Initiative for Asthma, and GINA is an organization that releases a global strategy to help with asthma management, and they employ advice from healthcare professionals as well as public health officials to come to their strategy, and they aim to increase the awareness of asthma and also improve asthma management as well. So just to orient ourselves, the primary goal of asthma management is to control the disease, and by doing so, reduce the risk of short and long-term complications. So that includes exacerbations and effects on function, declining lung function, morbidity, and mortality, of course. So looking at the criteria from GINA, what we see is that GINA looks at 4 characteristics. So over the past 4 weeks, for a patient to be well controlled, a patient would need daytime symptoms and need for reliever less than 3 times a week, and no asthma-related nighttime awakening, and no asthma-related activity limitations. So if they have 1 or 2 of those above characteristics, and they're partly controlled, and 3 to 4 of the above means that they're uncontrolled. So if you do look at the criteria here, it is possible and a realistic goal for patients to achieve 0 or minimal symptoms once their asthma is well controlled with the right management. And this should be a possible goal for all patients when you're considering in terms of personalized goals for them. So on the day-to-day basis, asthma has a huge impact on quality of life. The limitations and the anxieties surrounding asthma have a considerable impact on the emotional and physical aspects on the patient. So as you see on the slide, over 90% of patients with asthma do not have their asthma under control, and a large proportion of them actually miss out on things in their lives because of it. So they miss out on doing exercise, or they miss work or school or other social activities and other events in their lives. The fear of exacerbations can affect their quality of life and their ability to succeed in work and school. So pharmacists, again, are really in the ideal position to screen these patients with the tools that we're going to be talking about, and then also educate them on what's really possible with their asthma control.
Yeah, and it's really interesting, and it might be just because of how common asthma is in general, but I feel like a lot of patients take it for granted that it's normal and it's okay for asthma to interfere with their activities of daily living, and they just are willing to accept that as part of the disease, but they don't understand that is something that can actually be avoided if we help manage their asthma management. One interesting thing as well is that, as Molly said, we can have a realistic goal of having no symptoms, whereas for some other disease states with things like pain, we're often trying to manage expectations and trying to set realistic goals and not over-promising. But when we look at asthma, we should be saying, let's work towards no symptoms. So we don't want any nighttime awakeness. We don't want it to interfere with your daily activities. We don't want you to have to use relievers so often. So this is kind of an exciting thing because you can provide them with such good management, but definitely something you need to communicate to patients because they won't realize that it's even possible.
Exactly. Okay. So if we pause and think back to the GINA criteria as well, one of the indicators and characteristics of poor asthma control is, again, the use of a reliever 3 or more times per week. We know that asthma now is not just a condition of bronchoconstriction as it was thought to be in the past. There is an underlying inflammation present for asthma, even in patients with quote unquote mild asthma or infrequent symptoms. And it's been shown that SABAs do not improve asthma control in the long run. And also frequent use can reduce bronchodilator response to SABAs, which can affect when they actually need them during exacerbations. So again, it's not just the fact that SABAs don't work on asthma. We have evidence now that frequent use, so SABA-overuse and over-reliance, are harmful to patients. And it's not just the patients who are taking crazy amounts of SABA per day. As you see on the slide here, 3 or more canisters per year of SABA is associated with an increased risk of severe exacerbations, and 12 or more canisters per year of SABA is associated with an increased risk of asthma-related death.
Yeah, and when you reflect on your practice and your dispensing practice, I think everyone in attendance can even think about patients where they know, yeah, I am dispensing more than one SABA inhaler every season. And that's already for a year over the 3 canisters a year, which puts them at that increased risk of severe exacerbations and hospitalizations. We can probably even identify some patients who are getting 1 a month. And that would put them in the 12 or more canisters per year, where they have that associated with the increased risk of asthma-related death. So we really want to show you how to identify these patients, reflect on them, and then intervene for them to help them prevent these outcomes. One thing actually that we also see in some of the newer evidence that's available, specifically in the SABINA-2 trial, is that this affects Canadians. They looked at data in terms of SABA usage in many different countries, but they also had data from Alberta and Nova Scotia. And when we look at the Nova Scotia data, they found that about 60% of patients with asthma use 3 or more SABA canisters per year. So that's the majority of patients having that increased risk of severe exacerbations in Canada. So we know there's a population that can benefit from these new recommendations, and there's a role for pharmacists in identifying these patients.
Definitely, Tiana. We know that this affects Canadians, and definitely pharmacists have a big role to play in this as well. So now we come on to the change in practice. So First of all, let's do a throwback to the GINA recommendations from the past. And this has pretty much been the same recommendations as it had been for years and years. These guidelines were made when we didn't really know how important it was to address the inflammation in asthma. And again, in the past, asthma was thought to be mainly due to bronchoconstriction in the lungs as well, which is why SABAs were given often as the only therapy for patients with mild asthma. So now we're coming to the change. So we know that airway inflammation is essential to address in asthma. And in the updated GINA recommendations, SABA-only treatment is no longer recommended. So now all patients over the age of 12 require a ICS in their management. Symbicort, as you see at the bottom there, is also now the recommended reliever for all stages of asthma. And in mild asthma, it can be used PRN, and it will address the inflammation with the ICS component, and then also it can address the symptoms in the moment with the formoterol. And it's important to note that Symbicort is the only ICS LABA that's indicated as a reliever, as formoterol is the only one that works as fast as a SABA. And ICS formoterol, or Symbicort, is also reliever of choice in the upper stages of asthma as well, as long as the patient is also using Symbicort as maintenance. So based on these guidelines, it's kind of interesting to think that new patients that are diagnosed with asthma now may never actually use a SABA inhaler and may just be started on Symbicort. Okay. So now let's talk briefly, very quickly, about some of the trials that went into the new recommendations. And there were two that were really important, called the Symbicort given in mild asthma trials, so SYGMA trials. And there were two blinded randomized control trials with over 8,000 patients studied. And these were patients with mild asthma that they looked at. And they looked at mainly asthma symptom control as well as exacerbations. So the number of exacerbations and the time to first exacerbation. So closer up on the SYGMA-1 trial, SYGMA-1 compared Symbicort PRN to SABA-PRN, which was terbutaline in this case, to SABA-PRN plus a standing dose ICS. So that was terbutaline and budesonide BID. So SYGMA-1 found that Symbicort actually led to a 64% reduction in exacerbations compared to using a SABA-PRN alone. And regular standing dose ICS led to an improvement in asthma over Symbicort, but even though it did lead to an improvement, there was no difference in the exacerbation rates. So the exacerbation rates were similar. So SYGMA-2 took a closer look at Symbicort compared to the standing dose ICS plus SABA-PRN. And here there was an improvement with the ICS standing dose with regards to asthma symptom control again. But again, they found no significant difference in the rate of severe exacerbation. So there was a similar rate and number of flare-ups as well. So at the end, Symbicort was non-inferior to the ICS standing dose plus SABA-PRN. And also, they found it significantly reduced the steroid exposure for patients. So patients who were in the Symbicort cohort actually were exposed to 75% less steroids than in the standing dose ICS. So what's the bottom line after all of that for pharmacists? So at the end of the day, all your patients on SABA monotherapy should be switched to an either ICS LABA, which is Symbicort, as reliever, or they can be switched to ICS plus SABA, either used as daily dose ICS, so maintenance, either daily or BID, depending on the product. Or in patients with very mild stage 1 asthma, you can consider adding on an ICS inhaler separately every time they use their SABA, so together PRN.
Yeah, so to really reiterate which is the best choice, it does come down not only to the evidence, but also to the patient-specific situation. So we do want to identify patients who are currently on SABA monotherapy or who are on SABA therapy as well as other inhalers, but might have SABA overuse. And then we want to bring them to one of the two options that are now recommended according to GINA. So the decision can be made on a few different patient factors. For an ICS-LABA, where Symbicort is the only one that's been studied and has the evidence to support its use like this, we see the benefits in terms of convenience. So still being able to use just a PRN medication for patients with mild asthma, which can be nice if people aren't yet ready to integrate something into their life every day or twice a day. We have the emphasis on steroid exposure. So a lot of patients are concerned about that steroid exposure, especially in younger individuals. And these are the recommendations for adults and adolescents 12 plus. So one of the nice things here is that we have that lower steroid exposure. So that can be a benefit here too. And the last one is that safety, avoiding the risks of the SABA-monotherapy or overuse. However, there will be circumstances where the other options are best suited, the other ICS-containing options for your patient. Some of those can be in terms of symptom control. So in SYGMA-1, there were additional weeks of asthma control with the ICS and SABA option. So that can be something to have a conversation with the patient about. The other is that the cost can come into play. So Molly will review further in the presentation specific LU criteria and public coverage that hasn't exactly caught up yet. So for patients where affording the medication or something that has to be publicly covered is necessary, they might have ICS and SABA as their preferred option for the time being.
Yeah. And just wanted to point out as well that especially in mild asthma management, adherence is a huge concern. So when GINA made the recommendations for Symbicort, they really prioritized the fact that there is that adherence benefit to that one product. And then also there's the safety aspect. So patients never having a chance to be exposed to that SABA-only treatment, which we know is dangerous. So they really prioritized those two factors when they made that recommendation for Symbicort for mild asthma. In addition, compliance, again, can also be due to a variety of factors, and it's important to tease out the exact reason why if patients are having an issue with compliance, because that will affect the treatment that is best for them as well.
Molly, before we go on to the next section, it looks like we have some questions. Okay. Let me know if you think we have time to address them now. Like I'll read them, but if it's best to hold off or there's a slide that'll touch on them, we can definitely hold off as well. One of the questions came in, what about Zenhale? So that would be the mometasone formoterol inhaler.
Yeah. Yeah, so that's a really good question. And actually in practice, I have seen this, and there are certain clinicians I find that really do like the Zenhale option as well. However, regarding the GINA recommendations, so Symbicort is the one that is indicated in Canada for reliever therapy in this case. And I believe Zenhale does not have that indication as yet.
Yeah, and I think when we look too at the primary literature, which is what informed those recommendations, but also what informs our comfort making it as well, the inhaler that has been studied is Symbicort. So it does make sense if the patient is able to use it in terms of the Turbuhaler device and cost is appropriate, that would be our go-to for the ICS-LABA.
Exactly. Okay.
There's one other question, and it's, has the Canadian Thoracic Society changed its guidelines as well?
Okay, so that's a really good question. And I was wondering that as well as I was diving into this presentation. So the Canadian Thoracic Society, their recommendations and their guidelines have been delayed due to COVID. So hopefully they are coming out with new ones. They still have the previous ones from 2012, I believe, which is why we really focused on GINA in this presentation. So hopefully as they come out with their new recommendations, that can be included in your consideration and assessment as well. Okay.
And if anyone wants us to let them know when these do come out or would like a copy or to be redirected to the GINA guidelines or to the CTS guidelines once they are available, just send us an email. Our contact info is at the end of the presentation, and we can make sure to distribute those or information on where to access them.
Definitely. Okay, so now after we talked about some of the evidence and the changing recommendations, let's go into how to actually make these changes and what tools are available, what resources are available for pharmacists in integrating this change into your pharmacy practice. So we've kind of laid out a workflow integration for you. So to integrate this into your workflow, we can go over a few steps. So number one would be identifying at-risk patients, which we'll go over in the next slide. And then following the identification is addressing and assessing the patient's asthma control, followed by education, and then coming up with a recommendation together. Following, also assessing any opportunities for adjunctive therapy, so addressing any comorbidities or, for example, smoking cessation. And then, of course, always monitoring and following up as asthma control does not stay static and waxes and wanes as well. Okay. So for identifying at-risk patients, our target patients are really those who are on SABA monotherapy or those who have a SABA and ICS on file, but perhaps they're not very adherent to their ICS, or of course those you find that are using their SABA inhalers more than they should. So again, remember that threshold that we talked about with 3 or more SABA inhalers per year, kind of being that indicator for SABA overuse. So the ways in which we can identify this is number one, proactively through our SABA usage reports. So using our pharmacy software to generate reports on SABA usages, which we'll address in the next slide briefly, excuse me. And then we can do this passively as well. So providing self-assessment tools to patients or online questionnaires. And then also if patients come into the pharmacy, we can do it actively again. So during our patient discussion with them, assessing their asthma control, assessing their goals of therapy, and then we'll have tools that we'll talk about for that as well.
Yeah, and one thing that's really nice about the tools that Molly is going to show us in the next couple slides is that a lot of them can be integrated into existing practice at pickup or drop off, but also in existing clinical services. So you can make it a goal, for example, for anyone who has an inhaler, when you do a meds check, that you also get them to fill out one of these assessment tools while they're either waiting or you're completing some other paperwork. And so that can be a really good opportunity to integrate checking in on their asthma and making sure it's optimized into your practice. What we're seeing now as well with COVID is that some of the meds checks are being done virtually. And so that can be a good opportunity to assess asthma inhaler usage and comfort for patients in using the inhaler and technique appropriately. It can be a bit difficult in the pharmacy because that would require them to remove their mask. But from the home environment, you could address inhaler technique as well and ask them to show you that. One other thing that I wanted to point out is that these ways to identify at-risk patients that Molly has brought up are not just for the pharmacists. I think there's a really big role for the entire pharmacy team to play a part. When we look at SABA usage reports, that's something that the pharmacy technicians and assistants are able to do, and even do the phone calls with patients to kind of initiate the conversation and let them know they've been identified and the pharmacist would like to speak with them further. When we look at patients who are buying aero chambers, that can be an opportunity for even someone checking them out at the cash to say, I see you're buying an aero chamber. Have you talked to the pharmacist about your asthma control and improving your asthma control? So definitely a team-based approach to start the conversations with patients.
Definitely, Tiana. Lots of opportunities for pharmacists to really intervene and make these recommendations. So this is the SABA usage reports that I was just talking about on the previous slide. And so you can use your pharmacy software and put in the parameters to generate these reports to identify patients that maybe have been overusing their SABA or on SABA monotherapy. So if you're part of Whole Health, we've actually included laminated copies of these manuals that we've created to help you in generating these reports. And we hope that these will help you and also your team members as well. So not just pharmacists, but other pharmacy team members can help generate these reports to help identify patients as well. So this is the asthma 30-second control test, and it's an example of a virtual way that you can get patients to self-assess their control. It was developed by Breathe the Lung Association, and it's quite helpful because it's very quick, only 30 seconds, and there's 9 questions involved. And it does, these questions are based on the Canadian Thoracic Society, which are pretty similar to the GINA criteria, although a few differences, but still is a good measure of asthma control in patients, just preliminary. And this can be linked to your social media and can be helpful to reach patients that otherwise maybe wouldn't be comfortable to talk to you about their asthma control as yet. So this gives them kind of the autonomy to do this themselves, get a little bit of feedback from this control test, maybe do a little bit more reading on their own if they're not comfortable to talk to you yet, and then when they're ready, come talk to you. This is another example of a self-assessment. So the Blue Reliever Reliance test was developed by the Asthma Right Care Group and the International Primary Care Respiratory Group. And it assesses SABA use, but not only SABA use, but also assesses how reliant patients are based on the answers. So for example, one of the questions is, using my Blue rescue inhaler to treat symptoms is the best way to keep on top of my asthma. And based on the answers that patients give to these questions, they're given a score of over-reliance. And remember, when patients are over-reliant and overusing their SABA, that can put them at risk to some of the dangers of SABA overuse. So once you get the score, it can help you to frame your conversations with patients and to really address things that they could be concerned about.
Yeah, and this Blue Reliever Reliance test, as well as the prior one that Molly showed, can really help patients who are even in the pre-contemplative stage and aren't yet ready to change, but you can start to lay the groundwork for them to kind of say, okay, maybe I am over-reliant and maybe I do use my SABA inhaler as a bit of a safety blanket, and there might be some risks associated with that. And the ways that pharmacists can have this available, again, we discussed having it in a meds check. It can also be posted to your website. A lot of pharmacies now are having patients go to their website for booking things like flu shots or printing out flu consent forms and filling them out and bringing them in. Very similarly, this could be on your website for them to print out, complete, and bring in with them when they pick up their inhalers or their next medications. And that can give you some time to then generate a conversation at their next refill or when you call to follow up with them.
Exactly. Oops. Okay, so we just wanted to bring up this slide again just to remind everyone about the GINA criteria. And the reason why I love GINA is it's so simple. There's only 4 characteristics that you're looking at here, and it can be done fairly quickly for patients. So it doesn't have to take all day. It's quick and it is effective at assessing their asthma control. And again, for our whole health pharmacies, we have developed a tool that includes this criteria along with some details from the Canadian Thoracic Society, as well as a tool on the next slide that we'll be talking about just as a convenient resource for you when you're assessing asthma control. So this resource here is the asthma slide rule developed by Asthma Right Care. And I personally really love this tool because sometimes when you're talking to patients, I find it's very hard to actually visualize how much SABA they're using, especially when they're giving you an answer like, oh, I use 3 puffs per day or 4 puffs per day. How many inhalers does that actually come out to be? I don't know about you guys, but I can't do that mental math in my mind. So this tool helps you look out for SABA overuse. And as you remember from the previous slides, using that number 3 or more inhalers per year really starts to put them at increased risk of exacerbations and then risk of death when they use 12 or more per year.
Yeah, so I really like this tool as well. I find it's really nice and color coded, and patients really identify with, okay, green, I'm okay, yellow, okay, things are getting a bit risky, and red, okay, I really am using too much. And so this can be a really visual tool for patients as well. The way that you use it is you'll go to the left, and there's a few different questions you can ask patients, and different ones might resonate with different people. Depending on how they quantify their SABA use. So the questions are the number of SABA inhaler prescriptions per year, the puffs of SABA used per week, and the puffs of SABA used per day. So a patient could give you any one answer. For example, maybe they only use 2 puffs of SABA per day. So when we go to the left in the puffs of SABA used per day, that's the 4th row, and we move over to the right to the 2, we see that that is actually already in that yellow area. And when we look at the number of SABA inhalers that it corresponds with, if we look further up, that's in the 3 to 4 canisters per year already, which, as we know, puts them at risk of severe exacerbations. So can be a really good way to quantify it when, okay, 2 doesn't sound like too many, but then you get to the number of canisters, that can be a good opportunity to have the conversation with patients about the risks. And the other thing that these tools can be really helpful for in terms of quantifying where the patient's asthma stands is that they can actually be included along with pharmaceutical recommendations or opinions to prescribers, showing them not just that recommendation, but the reason and the information that's informing that recommendation.
Exactly. Okay, so we just included this slide to really point out how important it is to have patient buy-in, as shared decision-making is extremely important for patients to, number one, understand why they're making any changes in their therapy, and it's important for their satisfaction and adherence as well. So in terms of points of consideration from the patient, it would be important to point out the harms of SABA monotherapy or overuse, because for patients, this is very confusing. Throughout their asthma journey, they've heard varying messages from us, from stick to your blue inhaler, from it's fine to use your blue inhaler for however many times per day or per week. And now we're telling them the opposite. So it's really pointing out the fact that we have new information now. It's not their fault per se that they may be uncontrolled or they may be relying on their SABA inhaler. Pointing out that we have this new information. We just want to make sure that we're giving them the best therapy, the best recommendations for them now. One of the other concerns that we hear from patients is that they're concerned about taking inhaled corticosteroid due to the steroid component of it, which is understandable. However, it really is important to educate them about the benefits of ICS as well. So the fact that it reduces hospitalizations, it reduces asthma-related deaths. It's effective at preventing worsening symptoms, at improving lung function. So it is really important to balance those against the fears of side effects. Another component is the convenience aspect. So kind of getting buy-in by letting them know that if they switch over, it doesn't mean that they have to have 2 inhalers now to get an ICS component. With Symbicort, they can use just 1 inhaler, and it's still just the one that they need for a reliever as well. And then oh, sorry. Go ahead.
Yeah, I was just, I'm agreeing with Molly. I'm saying that that can be a great way to get buy-in, and it'll be really specific to the patient in terms of which of these is most significant, and also in terms of setting personalized goals. So when we're doing those assessments in terms of does it interfere with your sleep or your activities, then using that again later on to say, okay, what is your goal from switching over therapy? One thing as well, because we know a lot of people are so reliant on their SABAs because they get that immediate relief of breathlessness, is to not tell them they can't use it or to take it away, or to say we're never going back to that. It can be helpful to get buy-in by saying, okay, let's try this new therapy for a couple months, see if your symptoms improve, and if not, we can go back to the drawing board. Maybe it means you need to be stepped up. Maybe it means we switch over to ICS SABA. There are a few different ways and options available to manage patients' asthma. So letting them know that it's not an all or nothing, we can always revisit it as well.
Yes, definitely. Additionally, the last point that I was just going to make as well is the cost component, which can be a significant consideration and a significant barrier to many patients, unfortunately. So it is really important to bring this up with them and help them navigate this as well. And in situations where costs can be prohibitive to use Symbicort, for example, then using the ICS component and SABA in separate inhalers could be the option.
Yeah, and I think on this point, actually, there's a question or kind of a kind of a question here, where one of our pharmacists has said, are the makers of Symbicort considering an inhaler with less doses, for example, 60 doses for PRN use in patients with mild asthma who might not use it as frequently? So I don't think, Molly, you're expected to know the answer to this, but I think that is a really good, that's a good idea for patients that would reduce the cost. And I know we have some attendees here from AstraZeneca, so you don't have to answer that, but maybe something to consider on the cost front.
Yeah, definitely, because definitely it is a high cost for some of these medications. And if they're using it infrequently, especially patients who maybe have 1 to 2 times per month when they might need the reliever inhaler, I can see why that would be a great alternative or option for them. So that's a great question for sure. Okay. So going on to step 2. So after we have identified the patients and spoken to them, talked about the new recommendations and assessed their asthma control, then depending on your jurisdiction and your prescribing authority, you could be able to either send a pharmaceutical opinion or recommendation, or, and this is more so for our colleagues in Alberta and Saskatchewan, New Brunswick, in certain working environments, then if you're comfortable writing a new prescription for the patient. And it's important here, again, that before you do this, to really come to the decision for what you're going to go forward with in addition to the patient. So making sure it's a shared decision.
And I see a few comments. I see even on Facebook here, again, people reiterating that cost can be a barrier to change. So Molly will walk us through some options available. I also see Rita here from AstraZeneca, and she does say that they will take this feedback back to AstraZeneca about the size of the Symbicort. So thank you everyone for mentioning that feedback.
Yeah, that's awesome. Okay. So this slide here, we're going over some of the public coverage criteria in Canada in some of our provinces. Looking at this, we see that the coverage has not yet caught up with the evidence and what we've just talked about with the updated asthma recommendations. So it can be quite difficult at times, because usually in terms of eligibility, provinces will usually require patients to have previously tried an ICS and not have been fully protected or not be fully efficacious with that ICS dose. So not controlled with ICS, which can be difficult to follow the newer recommendations, where now we're saying ICS LABA before an ICS. So very difficult to navigate.
Yeah, and so I think, again, that's when we have to keep in mind those cost barriers, especially for patients who don't have private coverage or where paying cash can be strenuous on their budgets overall. So especially for patients who need public coverage, that's again where an option like a standing ICS with the SABA PRN might be the preferred option, as they're generally a general benefit, not requiring an LU code or special authorization, and might be less expensive options for them. So definitely tailoring it to them, but either way, shifting away from that SABA-monotherapy to really align with the newer recommendations to have ICS-containing therapy at all stages for managing even mild asthma.
Okay.
And kind of on this note too, again, a comment here from Rita at AstraZeneca, which makes sense. She's saying that on the coverage front, the market access team is continuing to work with payers, and that makes sense. We see this a lot when we look at things like the ODB formulary. We can see guidelines changing. One that sticks out to me was C. diff recommendations that had changed, and it took a long time to get changes in terms of what's covered. So these are new updates. We want to make sure we're aware of them, but sometimes the public coverage takes a while to catch up, but work is still being done to get it to catch up.
Yeah, definitely thankful for everyone who's working on that front to support patients' ability to access these medications. So this slide here, we just wanted to touch up on some additional opportunities for adjunctive therapy. So number one, smoking cessation for all patients who smoke, especially those who have pulmonary conditions. It's recommended, and for most jurisdictions in Canada, we can prescribe them as pharmacists. There's also physical activity, which is also generally recommended for all patients, as it can improve your overall health and also can improve cardiopulmonary fitness as well. And it's important here for the physical activity part to assess it, just to make sure that patients are not avoiding it because of lack of control as well. There is a weight management component as well, especially for patients who are overweight. It has been shown that even a 5 to 10% reduction in weight can improve asthma control. And then also there's the comorbidities part. So comorbidities are actually a modifiable risk factor for asthma control. So if you can address comorbidities when they're present, and these include things like anxiety or GERD or rhinosinusitis, these things have been proven to worsen asthma control. So if you can address them with medication and control them, that can affect and improve the asthma as well. Okay. So throughout this presentation, we've really tried to point out tools and resources to facilitate optimizing therapy at a variety of steps, including the identification of patients, the assessment of their asthma control, the education component and recommendation component, and now the follow-up. So for follow-up, patients should be reassessed in 1 week if they recently had an exacerbation, or otherwise, for most patients with asthma, they should be reassessed every 3 to 12 months. Ideally in the pharmacy, getting a chance to assess their asthma control, their inhaler technique and adherence at least once a year would be really great for patients, and amazing for building patient relationships as well. And as for follow-up, use the tools that we discussed to address symptoms and control, as well as technique and adherence, because those things are all waxing and waning with asthma control. And I see a comment from one of our attendees, George, as well, was saying that the Lung Association is an amazing resource when training patients to use their asthma inhalers. That's completely true. They developed videos for each type of inhaler on the market right now. So it's really great for COVID when you might not be able to have that full training interaction. You can point them to the video as well, and that can help as well.
Yeah. And I think in terms of your follow-up, when you are assessing patients, you can use things like the Blue Reliever Reliance test and the asthma control assessments. If you have printed them out, you can actually scan them onto the patient profile, and you can then show your patients over time, where did they start from, which they might forget in later months, and what level of control did they have at the beginning of this journey compared to where they are now that you've optimized therapy and you've made some changes. So reminding them of how far they've come. This can also be really helpful for sharing with prescribers. A lot of the times, and especially now, prescribers have a lot of things to address in appointments, and they might be addressing the most acute issue, which might put asthma as its chronic condition more on the back burner. But if you're able to show patients progress to prescribers or the reason for needing a change, that can really build the pharmacist-prescriber relationship, because they can see you're also monitoring and being an allied health team member in monitoring chronic conditions that they might not be able to monitor as much given the current times.
Yeah, exactly. And also important to point out that patients with asthma, they're going to be needing their inhalers probably for the rest of their lives as well, right? So really building that relationship with them. If you can improve their life, their quality of life, and improve their ability to breathe, they'll be very, very thankful, and they'll be a very loyal patient as well. So it's an excellent way to connect with your patients. So we just wanted to go over some resources, additional resources that we may have not touched on yet. So in terms of program materials, there's just a selection on this page here of some of the materials that are provided to you as part of our respiratory program. So we have educational aids, such as our Therapeutics Thursdays, which go over the updated recommendations, as well as some other details from guidelines and GINA recommendations. We also have our counseling guide that highlights some patient frequently asked questions. It helps with some more questions about the coverage aspect, and it also helps to start conversations with patients as well. So conversational triggers are included in there. We also have operational aids such as our recommendation templates that are specific to this change in mild asthma treatment. And then, as I was talking about before, we have our assessment aid that we developed with the GINA recommendations on there. It's a convenient guide. It's laminated for you. It's got the asthma slide rule on there. And on the back, we also included a chart full of all of the available inhalers in Canada right now. And of course, we have our promotional materials. So the countertop display and social media tiles, just to make sure that you can really reach out to as many patients as possible.
Yeah, and we're getting some questions on Facebook here asking about the tools and if they're easily available. So a lot of the ones we talked about are available publicly for pharmacists. If there's anything that you see, perhaps you really like the assessment aid that Molly made, which I quite enjoy because it can really help visualize, and there's a few different tools. Plus on the back side, there's all the inhalers, so it can be a really good discussion piece and it is laminated, so if you use it with the patient, it can be easily wiped down using COVID precautions. But if there is anything you see here that you'd like access to, but you're not part of the banner, so you didn't receive these in the mail this week, my email and Molly's email will be at the end of this presentation. Just send us an email and we can get you these resources. We can even link you to the free resources that are whole health specific and point you in the right direction. One last comment on Facebook saying, who knew that the slider rule would make a comeback? But it is a great tool, so I'm glad it did.
Yeah, definitely. I love it for visualization. And it's great to show patients as well. Okay, so another component that we've included in this program is our personalized data reports that we've sent to the pharmacies. So I should have sent them to our whole health pharmacies this morning, the ones that have been with us since pre-COVID. As we all know, inhaler data went a little bit wonky after COVID hit. So in this report, we really break down your inhaler purchases by class. So you'll get to see the 5 months that you see there and broken down by SABA, Symbicort, ICS-LABA, and ICS. And we hope that these you find helpful just to visualize your purchasing patterns and see how they relate to the recommendations for asthma and maybe get an inkling of maybe which direction is best to go in as well.
Yeah, and so you can see on these reports, the 5 bar graphs on the left will be your pharmacy-specific data, whereas the rightmost bar graph is more of the recommendations to the newer recommendations that place less emphasis on SABA and more on the ICS-containing therapies. So when we looked at the data in our banner, we saw that pharmacies have their inhalers at more than 50% generally as SABA inhalers. But what we want to shift to is not completely eliminating it, but reducing that and having Symbicort, other ICS-LABAs, and ICS therapies really taking on a greater proportion of those dispensed for patients.
Yeah. And the last thing that we want to talk about as part of our program as well is that we're holding a focus group in early 2021. And the aim of this is really to gather some more patient and pharmacist feedback about these changes in asthma optimization, and also to assess any barriers and facilitators there are in the process of optimizing asthma control. So we have developed a focus group booklet with practice reflectives to help you document patient interactions, and these practice reflectives take into account certain considerations when it comes to these new changes. So operational considerations, clinical, and monitoring and follow-up as well. So overall, we're trying to get a better picture of what patients and pharmacists feel like in terms of changing their practice to follow the more updated recommendations.
Yeah, and we already have pharmacists that have volunteered to be a part of this focus group with us, but we do have some spots still available. So if you'd like to document interactions with at least 5 of your patients, just to get a different variety of feedback from them, maybe barriers to communications about the updated recommendations, or maybe things that they were really receptive to, and then participate in the focus group for an hour. We will provide dinner virtually, as well as an honorarium for participating. One thing I also want to point out is specific to patients who are using inhalers for asthma. It's not for the COPD at this time, and there is still a role for SABA usage in COPD management. So for some pharmacies, you might have, though, it's more for patients with COPD. And so these interactions for the focus group will be specific to those with asthma whose management has been impacted by the new recommendations and the new primary literature.
Yep, exactly. And just to add on to that point, in patients who have mixed asthma and COPD presentation, so we would actually treat them as asthma. So they would actually follow these new recommendations if they have that mixed condition. But definitely important to point out that SABAs do still have a role in other disease states. Okay, so thank you everyone for tuning in. I hope you enjoyed the session and took something out of it, whether that be resources or tools to help you integrate this change into your practice. I feel like there's a lot that pharmacists can do, and there's a lot of benefit that we can do both to patients and to our communities as a whole, starting with identifying that SABA overuse that puts patients at risk, and also identifying SABA monotherapy that, number one, doesn't work for asthma control in the first place. And then re-educating patients around their the possibilities with their asthma control as well. So I think we can play a huge part in empowering patients to improve their outcomes.
Yeah, and although there is a really big role for pharmacists, that doesn't mean you have to start big right away. Just pick one or even two action items that you want to integrate into your practice, and that can be as easy as printing out certain tests for patients to identify their asthma control and integrating those maybe for patients who use an inhaler in their meds check or at a refill for their medication. It can be as simple as that. And then once you become more comfortable with it, then you can expand that to maybe recommending it for everyone and being proactive in identifying and speaking with these patients. But start a little bit, make it a goal for 2021 to integrate this into your practice and monitor how you're doing and participate in our focus group.
Exactly. So let us know if you guys have any other questions. We will stay on for maybe a few more minutes just to see if anybody has anything else, but thank you so much.
Yeah, thank you so much for spending this evening with us. Again, a few different people had asked for resources, so our email addresses are tiana@wholehealthrx.ca and molly@wholehealthrx.ca, which can be easier to spell than Tiana. So just email either of us and we can get those resources to you, or any literature that you might have heard about in the presentation and want to read for yourself.
Definitely.
Okay, thank you so much.
Okay, thank you. Oh, we do have a question here, actually.
Oh.
Sorry. So is Symbicort also the recommended therapy for those using SABA before exercise? I think that's an excellent question, and I hope the person who asked is still on the line here. Sorry for not addressing it earlier. That's a great question. So actually, we have newfound evidence that Symbicort can actually be used prior to exercise as well, and can reduce the need for SABA before exercise. And it's important to note that if we go back to the GINA recommendations as well, if there is a need for SABA prior to exercise, that is an indicator of poor control, actually. So this patient would, if they need SABA before exercise, would probably need to be optimized on their therapy. And we do have more upcoming evidence that's in the GINA 2020 recommendations for Symbicort for this indication as well. Okay, so let us know if anybody has anything else.
Okay. And with that, we'll close the session. But if anyone thinks of anything that comes up once they've had some time to kind of digest, by all means, feel free to send us via email. Even if it comes up in a couple months from now, once you've engaged with patients, if you need any support finding answers for them, by all means, email either of us.
Yes, thank you so much, everyone. Really appreciate you spending your time to hang out with us this afternoon or this evening. Okay, bye-bye now.